Good evening, everybody. Welcome to another NeatMed tutorials. And today we'll be dealing with nephritic syndrome. Let's first define some things. Acute glomerular nephritis. So, acute glomerular nephritis is a group of diseases that's characterized anatomically by inflammatory alterations to the glomeruli and clinically by the syndrome of acute nephritis. So we have a glomerular inflammation that is giving us pictures of nephritic syndrome. So that's what we call acute glomerular nephritis. Now let's first understand what nephritic syndrome is. There's a fun mnemonic we used to use then, ho ho, like the laughter made by Santa Claus, ho ho, where H stands for hematuria, that's colored urine. O stands for oliguria, that's drop in urine output. H stands for hypertension, and the last O stands for edema, which is usually periorbital. I'm assuming we're using British English because if we're using American English to be whole hair. Anyways, so those are the major features of nephritic syndrome. We have hematuria. The hematuria now is usually microscopic, okay, because it's the casts that are present there, not whole red blood cells. We have proteinuria, but the proteinuria now is less than 3.5 grams per liter, so it's not in the nephrotic range. We have hypertension, which is due to salt and water retention. We have edema because of what the loss of protein and also due to the salt and water retention. But note, it is not as marked as status as a nephrotic syndrome. And we have oliguria. Now take note, some diseases or some glomerulonephritis can present with both nephritic and nephrotic presentation. Alright? So causes of it or diseases that are associated with it. Well, we have certain autoimmune diseases like the one that cause post-streptococcal glomerulonephritis. Group A, beta hemolytic streptococcus, that's Streptococcus pyogenes, is associated with certain autoimmune conditions. So, streptococcus that causes pharyngitis, that's not well treated, can lead to acute rheumatic fever, which, if not well treated, can progress to rheumatic heart disease. Also, streptococcal pharyngitis could also give post-streptococcal glomerulonephritis, but streptococcal impetigo cannot give acute rheumatic fever. It can only give post-streptococcal glomerulonephritis. Alright? We have other non-streptococcal glomerulonephritis. Those that can be caused by pneumococcus, hepatitis B, and hepatitis C. Remember in the nephrotic lecture, we spoke about hepatitis B causing membranous proliferative glomerulonephritis. Now, membranous proliferative glomerulonephritis can give both a nephrotic and a nephritic picture. There's usually an overlap between both of them. We have infective endocarditis. In endocarditis, a lot of the vegetations from the heart valve they break up, travel in the bloodstream, deposit in the kidneys, the immune complex goes there and they start a type 3 hypersensitivity reaction. And that can give a what? Nephritic picture. Now we have this Henoch-Schönlein syndrome. The Henoch-Schönlein syndrome is a type of vasculitis, usually a medium to small vessel vasculitis, alright? And it's formed by antibodies IgG directed against secretory IgA. So when they are deposited in the kidneys, they cause glomerulonephritis. They also can be deposited in the blood vessels, causing palpable purpura, deposited in the gastrointestinal tract, causing abdominal pain, deposited in the joints, causing what? Joint pain. Now take note, if somebody has IgG tag against IgA immune complex and deposits only in the kidneys, it is called Berger's disease, also called IgA nephropathy, and that gives a nephritic picture. Another one is Wegener's granulomatosis. Wegener's granulomatosis is a type of autoimmune disease characterized by both upper and lower respiratory tract symptoms. So the patient can have rhinitis, sinusitis, and also have cough with hemoptysis. And then there's also kidney involvement, and usually presents as a rapidly progressive glomerulonephritis that progresses faster to renal failure. Okay, So these are some common causes. Now, histologically, but the major cause of glomerulonephritis, we have the post-streptococcus glomerulonephritis, or the IgA nephropathy, or the rapidly progressive glomerulonephritis, and we have the diffuse proliferative glomerulonephritis. And the diffuse proliferative glomerulonephritis also gives somewhat nephrotic picture. It is the most common type of lupus nephritis. Systemic lupus erythematosus, an autoimmune disease, is the most common type of nephritis that occurs with lupus is diffuse proliferative glomerulonephritis, meaning that greater than 50% of the glomerulus of both kidneys are involved in the inflammatory process. So let's talk about the post-streptococcal glomerulonephritis or the active proliferative glomerulonephritis. I want you to think the streptococcus has certain proteins, usually the M protein. Now that M protein not only protects it and prevents it from having phagocytosis, it blocks the Fc fragments of the immunoglobulins from attaching to the receptors and then phagocytosing it. Okay. Now, what happens? The human body produces antibodies against that M protein. And when that occurs, they bind. And as they bind, they get deposited in what? Various organs. Now, the kidney is the organ that filters blood. So there's a very high chance that it will be deposited in the kidney, particularly in the glomerulus. And when it's deposited in the glomerulus, it triggers a type 3 hypersensitivity reaction. Okay, that's what I just spoke about. So now, what occurs? We have IgG against proteins of the streptococcal antigen. This immune complex triggers the complement system, particularly the classical pathway. Now, when the classical pathway is developed, what happens? We have the production of certain complement proteins. All right. It first begins with the activation of C1, go to C2. It leads to production of C3 convertase. C3 convertase then splits C3 into C3A and C3B, isn't it? And C3B together with C2B and C4 then forms C5 convertase, which then splits C5 into C5A and C5B. Now C5A is a neutrophil chemotaxis factor. So what happens? It attracts neutrophils to the site of the immune complex deposition. When neutrophils then release oxygen radicals, reactive oxygen species, and cytokines. Now, these cytokines and oxygen radicals released then damage the glomerulus and the basement membrane. Okay, and then gives us the pathogenesis of nephritic syndrome. All right, so there's inflammation and changes in the basement membrane. There's an increase in the permeability of the basement membrane. What happens is that proteins then can start leaking, so we can start seeing some form of what? Proteinuria, and also damage of the glomerulus will lead to a drop in the glomerular filtration rate. Okay. Now, pending the extent of the damage, then determines the degree of what the clinical presentation we might see. So, if the filtration is greatly reduced, we now start seeing a rise in the nitrogen containing compound, which is called azothermia. We can see acidosis, hyperkalemia, and hyperphosphatemia. So, remember, post-streptococcal glomerulonephritis is basically a type 3 hypersensitivity reaction, as is almost all causes of nephritic syndrome. So post-streptococcal, diffuse proliferative that is seen in lupus is usually type 3 hypersensitivity reaction. IgA nephropathy, similar, but rapidly progressive. Now we have different diseases that cause rapidly progressive. We have one that's associated with antibodies against glomerular basement membrane. Okay, it's called Goodpasture syndrome. A person presents with hemoptysis and also kidney involvement, and we have the one that's associated with Wegener's granulomatosis, which is canker, as C anchor. So these two are not straightforward immune complex deposition reactions. Okay, so the clinical features we've already spoken about it. Urine. So what we usually see is a young child develops malaise, fever, nausea, then oliguria and hematuria, usually described as cold colored urine. weeks after recovery from a sore throat or a skin infection, usually streptococcal impetigo. Okay, so keep that in your mind. And then we see the clinical presentation: red cell casts in urine, mild proteinuria, periorbital pedal edema, mild to moderate hypertension, or we could see there. All right. So severe complications, we got the hypertensive encephalopathy when there's convulsions, impaired consciousness. Now the brain has its auto-regulation mechanism, meaning that within set a wide range of blood pressure, the brain is still able to regulate the amount of perfusion it gets. But when the blood pressure has gone beyond the brain's ability to regulate it, we then develop hypertensive encephalopathy. Okay, it could go further to acute renal failure to the patient to pulmonary edema. The elevated blood pressure could put strain on the left ventricle because of an increase in afterload, leading to what? Heart failure. And then some diseases like we said about also have both nephrotic and nephritic pictures. So we also see nephrotic syndromes. Prolonged hypertension will lead to retinopathy. Rapidly progressive glomerulonephritis, like those caused by Wegener's granulomatosis and Goodpasture syndrome, can lead to renal failure rapidly. So this is the summary of the clinical features. This is the obstruction of the glomerular capillary by the immune complex, going to be reduced blood flow, leading to tubular epithelial damage, going to lead to fluid retention and what? Edema. Also, the reduced blood flow leads to diminished filtration, oliguria, rise in blood urea nitrogen, and also we're going to stimulate the juxtaglomerular apparatus because of the drop in renal perfusion pressure. Then we're going to have the RAS system, which is going to lead to rise in blood pressure and also increase sodium and fluid retention. Okay, and when the endothelium has been damaged itself, we're going to see a focal increase in permeability, proteins are going to be lost, red blood cells are going to be escaped, but they are going to what? Be damaged somehow and then form casts. So investigations, you want to do your for all renal pathologies, all you must do a kidney function test, and a basic kidney function test are the electrolytes, urea, and what? Creatinine. Then urinalysis can give us some hints which control blood or protein culture, so white blood cell casts, red blood cell casts, and then throat swab to find if there's any present ongoing streptococcal antigen. We can also do anti-streptolysin O or anti-DNase. Now, the complement system are usually reduced because many of them are being used up in the immune complex process. You will go to serum cholesterol to rule out a nephrotic syndrome if you are confused as to the clinical presentation, or if the protein range giving you about 3.3 or 3.4, you want to be sure there's not a nephrotic syndrome. You might do serum cholesterol to help you, because we know in nephrotic syndrome is hyperlipidemia. Do blood film for malaria parasite. If you suspect pulmonary edema, you do a chest x-ray, renal imaging, and renal biopsy, though it is rarely indicated. So management is usually supportive. You want to control the hypertension, you want to reduce volume load, you want to treat hyperkalemia, acidemia, hyperphosphatemia, and then antibiotics if the infection is still present. So you want to really adjust, control the BP, both pharmacological and what non-pharmacological. So there is what close follow-up. Okay. Now, if there is profound renal failure, like in a rapidly progressive one, you may then need to do renal replacement therapy. And then corticosteroids might also be there to influence the cause, because we use an autoimmune process, inflammatory process, and corticosteroids are strong anti-inflammatory agents, so they might have a role in management. Prognosis is usually good, especially the post-streptococcal glomerulonephritis, with 80% recovering and 10% may go into chronic renal failure. So it's necessary to follow them in adulthood. Thank you very much. See you next time.